Good morning, student. Today we'll see about proximal humerus fracture patient management protocol. Proximal humerus fracture are common injury, particularly among the adult over 65 years, accounting for approximately 5% of all the fractures. Our primary goal is to restore optimal shoulder function and minimize the patient pain. Then we'll go for epidemiology and relevant anatomies. The incidence and mechanisms. 75% occurs in the patient 60 years, more than 60 years old, with a 2:1 female predominance. Then low energy falls cause fracture in the osteopathic elderly. Then high energy trauma leads to fracture in the young adult. Then anatomy and vascularity. There is a four main segment: head, greater tuberosity, less tuberosity, and surgical neck. Compromised blood supply from the circumflex humeral arteries can lead to avascular necrosis. Now, classification systems. The knee classification is the most widely used system, categorizing the fracture based on number of the displaced parts. There is a displacement more than 1 centimeter or angulation 40 feet more than 45 degree. Then fracture pattern dictate treatment decision prognosis. Two-part fracture is the surgical neck is the most common fracture. Then involved of the greater tuberosity and lesser tuberosity. Then three-part fracture is the surgical neck plus one tuberosity. Four-part fracture, surgical neck, both tuberosity, then articular head replacement. Then diagnosis and initial management. The clinical presentation is the pain, swelling, ecchymiosis, and decreased range of motion. Imagine the anteroposterior and true scapular view and the axillary lateral X-ray are essential for diagnosis. CT scan is recommended for complex, displaced, or intra-articular fractures due to either surgical planning. Then initial step, sling immobilization, effective pain management, and through neurovascular assessment, there is an axillary nerve injury occurs in the 10% of the cases. The non-operative management protocol. Indication: minimally displaced less than 1 centimeter or minimally angulated less than 45 degree for the accounting for 80 to 85% of cases. Then protocol: arm slings for 3 to 6 weeks, followed by early gentle range of motion for pendulum exercise, shoulder pendulum exercise. Then focus pain control and gradual return to function, and often superior to surgery for stable fractures. Then outcome: acceptable functional result in the 70 to 90% of the appropriately surgery cases. Then operative management of the indication mode techniques. Indication: they are displaced 2, 3, 4-part fracture, incur active patients or concomitant neurovascular injuries. There is a ORIF, open direction internal fixation. The locking plate or screw systems are commonly for reconstructible fractures. Then IM nailing. The intramedullary nailing is alternative for some surgical neck fractures. Then arthroplasty. The hemiarthroplasty or reverse total shoulder arthroplasty commuted 4-part fracture, the avascular necrosis, and the elderly patient, the quality of life. Then post-treatment rehabilitation protocol. Full recovery from the proximal humerus fracture can take 6 to 12 months. Then with a strong focus on the restoring mobility and strength through the structured rehabilitation protocol. Then phase 1, there is a 0 to 6 weeks. Can use it for immobilization for the sling, then pain, edema control, then gentle pendular exercise. Then you will go for phase 2, 6 to 12 weeks. That is a gradual increase in the passive and active assisted range of motion of shoulder. Then phase 3 is a 12 to 24 weeks. There is a progressive active range of motion and light strengthening exercise. Then phase 4, the 24 weeks. There is advanced strengthening and functional activity or sports work. Conclusion of the key takeaways: management of the proximal humerus fracture is proximal humerus fracture is highly individualized. The decision making balance fracture pattern, patient age, and bone quality and functional demand. This is a very important point out. Then non-operative treatment remains the gold standard for most minimally displaced fractures. Then rehabilitation is crucial for optimal functional outcome and regardless of the treatment type. These are the conclusion. First, we mainly see about the which type of the fracture. Then we will go for pattern of fracture, patient age, then bone quality, then functional demand. Then you will go for decide the undisplaced fracture. You will go for gold standard method of the non-operative management. That is a very good. Then it's a operative, it's cumulative fracture, 2-part, 3-part, 4-part fracture. These are the fractures you will go for prescribed patient age, bone quality, you will go for operative management. That is a ORI, open directional fixation, EM. These are methods commonly used for that. Then you will go for rehabilitation. Rehabilitation mainly crucial income, the functional outcome. That is both are operative and non-operative management.